My name is Human Poor from the Division of Pulmonary Critical Care and Sleep Medicine at Mount Sinai. I'm going to discuss the basics of mechanical ventilation for the COVID-19 patient. This talk is geared predominantly for providers who do not routinely use ventilators for critically ill patients. I do not have any financial disclosures. I'm going to discuss the rationale of positive pressure ventilation for patients with ARDS secondary to COVID-19. I'll review the basics of volume-controlled ventilation, and I'll explain how to set and adjust the important parameters in volume-controlled ventilation for COVID-19 patients with ARDS. The predominant way that COVID-19 leads to respiratory failure is by causing ARDS. As a review, ARDS is a syndrome that is acute. It presents with bilateral opacities on chest imaging. The PaO2 to FiO2 ratio is less than 300 when PEEP is greater than 5. And these abnormalities are not completely explained by cardiac failure or volume overload. The pathophysiology of ARDS begins with lung injury and inflammation. The lung injury and inflammation create leaky capillaries and leaky alveoli. As a result, alveoli fill up with fluid, and gas exchange is impaired. COVID-19 patients can be profoundly hypoxemic. The alveoli will collapse, and with all of the pulmonary edema, the lungs become stiffer. Patients ultimately develop respiratory failure. Ventilators are frequently required to support patients with ARDS. They deliver high amounts of oxygen and can achieve FiO2s as high as 100%. They provide positive pressure to reduce the work of breathing. A ventilator pushes air in so muscles of inspiration do not have to work as hard to suck air in. And they also provide positive end expiratory pressure, also known as PEEP. PEEP prevents open alveoli from collapsing. To understand how a ventilator works, it's important to understand how one can inflate a pair of lungs. You can either increase the pressure inside of the lungs, known as the alveolar pressure, or you can decrease the pressure outside of the lungs, which is the pleural pressure. When we inflate the lungs by decreasing the pleural pressure, that's spontaneous ventilation. We contract our muscles of inspiration, our diaphragms descend, the intrathoracic pressure decreases, and therefore the pleural pressure decreases, and the lungs inflate. When we inflate the lungs by increasing alveolar pressure, that's positive pressure ventilation. To understand breathing, it can be helpful to compare it to an electric circuit, where a voltage difference is equal to the current of electrons times the resistance. Except instead of a voltage difference, we have a pressure difference, and that pressure difference is between the airway pressure at the mouth and the alveolar pressure in the lungs. That difference is equal to the flow of air, Q, times the resistance of the system, R. When we rearrange the equation, we have an equation for the flow in and out of the patient, Q. With spontaneous ventilation, the diaphragms descend, intrathoracic pressure decreases, and as a result, there's a drop in alveolar pressure. The alveolar pressure is now less than proximal airway pressure, and that results in flow going into the patient. So in spontaneous ventilation, one sucks air into the lungs. Now compare that to positive pressure ventilation. With positive pressure ventilation, the ventilator increases proximal airway pressure. This pressure is now greater than alveolar pressure, and it results in flow also going into the patient. So with positive pressure ventilation, the ventilator pushes air into the lungs. There are many modes of ventilation on modern ventilators, but regardless of the mode of ventilation, the ventilator increases airway pressure for a set time, and that results in airflow into the patient, and it culminates in a delivered tidal volume. Phase variables determine the mode of ventilation. They are essentially ventilator instructions that determine when and how breaths are delivered. One can view the phase variables as the components that make up a breath. There is the trigger, and that determines when inspiration begins. The target is how flow is delivered during inspiration. Cycle determines when inspiration ends. And the baseline is proximal airway pressure during expiration. So you can mix and match the phase variables to essentially create the different modes of ventilation. But as my kids will tell you, for the sake of simplicity, you should use volume-controlled ventilation. Let's start with the first phase variable, the trigger. The trigger determines who initiates the breath. A breath can be initiated by the ventilator or the patient. For a ventilator-triggered breath, this is known as a control breath. The variable that is set is time. However, on the ventilator, we don't really set the time, we set a respiratory rate, and that's because the frequency is the inverse of time. So a respiratory rate of 12 breaths per minute is equal to 1 breath every 5 seconds. A patient-triggered breath is also known as an assisted breath. Flow or pressure changes sensed by the ventilator as a result of patient efforts will trigger this breath. If we combine the assist trigger with the control trigger, we get a hybrid trigger known as assist control. It's important to note that assist control refers only to the trigger, not to any other aspect of the breath. And volume-controlled ventilation uses assist control as the trigger mechanism. The question that arises is, with this hybrid trigger mechanism, how much will be assist and how much will be control? For a given patient, let's set the respiratory rate, the control respiratory rate, to 10 breaths per minute. So that means 1 breath every 6 seconds. And assume that the patient's brain is firing inspiratory signals 20 times per minute. So that's 1 breath every 3 seconds. What percentage of breaths will be assist and what percentage will be control? Well, one would think it would be some combination of assist and control breaths because you have both available, but it turns out that 100% of the breaths will be assisted breaths. And that's because the control rate clock resets after every assist breath. There will never be a 6-second time period without any breath. Now, instead of 10 breaths per minute for the control respiratory rate, let's make it 30 breaths per minute. And that means 1 breath every 2 seconds. So again, the question is, what percentage of the breaths will be assist, and what percentage will be control? In this case, 100% of the breaths will be control. Here's a screenshot of one of our ventilators. You can see here is where we set the control respiratory rate. And up here tells us whether the last breath was a control breath or an assist breath. And here tells us what the actual respiratory rate is of the patient. Note that if this respiratory rate is higher than the control respiratory rate that we've set, the patient must be triggering at least some of the breaths. Let's move on to the next phase variable, the target. The target tells us how flow is delivered during inspiration. In volume-controlled ventilation, we actually set the flow rate. You can set the flow rate to be constant during inspiration, or you can set it as a decelerating ramp, where flow is highest at the beginning of inspiration and tapers off during the breath. Most commonly at Mount Sinai, we use the decelerating ramp flow pattern. Again, this is the screenshot of our ventilator. You can see the decelerating ramp shape of our flow pattern and the peak inspiratory flow rate that is set. Here are the flow and pressure curves on the display of the ventilator. Volume-controlled ventilation is a flow-targeted mode. That means the flow is set by us, and the pressure curve will be determined by the flow pattern and characteristics of the respiratory system. Here is the equation for flow. Flow will not change with changes in the respiratory system. So if the resistance goes up, or there are changes in compliance, or there are respiratory efforts altering alveolar pressure, the flow will never change. We have set it, and the ventilator follows those instructions. However, if there are changes in the respiratory system, whether it be resistance or compliance or changes in respiratory effort by the patient, the airway pressure will change. Those changes in airway pressure can be seen on the ventilator display. You can see them on the pressure waveform here. You can also numerically see it as the peak pressure up here. To illustrate what it means to be flow targeted, assume that a patient bites the endotracheal tube. This will result in an increase in resistance in the respiratory system. Because we are in a flow-targeted mode, the flow will not change. As a result, the ventilator has to increase the airway pressure. If this airway pressure increase is high enough, the pressure alarm will go off, and that alarm you have undoubtedly heard numerous times before. Now let's say, for example, that instead of the patient biting the tube, the patient makes a sustained inspiratory effort. The patient is using the muscles of inspiration, using their diaphragm. That results in a drop in the alveolar pressure. Again, we are in a flow-targeted mode, and flow remains unchanged. The ventilator is loyal to our instructions that flow is set. Because flow is unchanged and alveolar pressure has now dropped, the airway pressure now must drop. And we can see this on the pressure waveforms, where divots can appear in the pressure waveform when the patient makes an inspiratory effort. The third phase variable is known as the cycle. The cycle determines when inspiration ends. In volume control ventilation, volume is the cycle. When we look at our flow curve that we have set, volume is merely the area under the curve of this flow pattern. In our display here, this is where we set the tidal volume. It's important to note that the ventilator also measures the tidal volume coming back to the ventilator. This is known as the exhaled return volume. And in general, these two volumes should be about the same. While ventilators are life-saving devices, they can themselves perpetuate and exacerbate lung injury. Specifically, high tidal volume in ARDS causes lung stretch and further lung damage. This is what is known as volutrauma. To mitigate this, low tidal volume ventilation is essential. When we do low tidal volume ventilation, we set the tidal volume to 6 cc's per kg of ideal body weight. It's important to use ideal body weight and not actual body weight, because when you gain a significant amount of weight, whether it be fat or muscle, your lungs don't actually grow. Low tidal volume ventilation can be uncomfortable for patients, and so you'll likely need to use sedation and sometimes even paralysis to achieve it. Finally, the last phase variable is known as the baseline. This determines what the proximal airway pressure is during expiration. It's also known as the PEEP. The pulmonary edema in ARDS causes many of the alveoli to collapse. The repetitive opening and closing of alveoli causes further lung damage. This is what's known as atelect trauma. PEEP prevents open alveoli from closing. Additionally, maintaining alveoli open will improve gas exchange. Here's the ARDS protocol, and I recommend using the high PEEP ladder. This dictates what PEEP to use for a given FiO2 when you're trying to achieve a PaO2 of 55 to 80 or an oxygen saturation of 88 to 95%. COVID-19 patients appear to be very PEEP responsive, which means that PEEP seems to help prevent alveoli from collapsing. However, I would not increase the PEEP above 16 centimeters of water without the guidance from a critical care physician. Here is the display of the ventilator. This is where we set the PEEP, and here is where we set the FiO2. Next is the plateau pressure. The plateau pressure is an estimate of the maximum pressure in the alveolus during the respiratory cycle. To measure the plateau pressure, you must perform an inspiratory pause maneuver. With this maneuver, after a tidal volume is delivered, the expiratory valve remains shut and air does not leave the patient. Pressure measured at the end of the maneuver is called the plateau pressure. High plateau pressures can lead to barotrauma, specifically pneumothorax and pneumomediastinum. The goal plateau pressure in ARDS is less than 30 centimeters of water. Here is again the display of the ventilator. The last breath is where the inspiratory pause maneuver was performed. And you can see that the measured plateau pressure was 13. So let's say your COVID-19 patient just got intubated. You should place the patient on volume-controlled ventilation, set the respiratory rate to 20 breaths per minute, set the tidal volume to 6 cc's per kg of ideal body weight, set the FiO2 to 100%, set the PEEP to 15 centimeters of water, and then perform an inspiratory pause maneuver to check the plateau pressure. If the plateau pressure is greater than 30 centimeters of water, reduce the tidal volume to 5 cc's per kg. That will bring down the plateau pressure. If despite reducing the tidal volume, the plateau pressure is greater than 30 centimeters of water, you should call for help. Ensure your patient is well sedated, and check an ABG or VBG about 30 minutes after settings have been adjusted to ensure that the pH is appropriate. If the pH is less than 7.2, increase the respiratory rate. The maximum respiratory rate you can set is 35 breaths per minute. As your COVID-19 patient is improving from a respiratory standpoint and requiring less support on the ventilator, you should wean the FiO2 and PEEP as per the ARDS ladder to ensure that the oxygen saturation is between 88 and 95%. Wait at least 12 hours between changes in PEEP. If you're interested in learning more about the basics of mechanical ventilation, my book is available online via the Levy Library website. Good luck.